Welcome to The Scope with Dr. K. I'm Dr. Kosinski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology when possible, but also outside of GI as well. Our guest today is Don Calcagno, Senior Vice President, Chief Population Health Officer, and President of Advocate Physician Partners at Advocate Aurora Health. He leads innovative programs to improve quality while lowering the total cost of care and managing several $billion of financial risk. His scope includes the management of over 2 million value-based lives attributed through 70 value-based and capitated contracts across 6 states. Small job. He also leads one of the most mature and successful clinically integrated networks in the country. Don's had 30 years of experience across population health, managed care, operations, clinical integration, accountable care, process improvement, analytics, research, and laboratory sciences, which was at his core. Under his leadership, Advocate Aurora Health became a national leader in value-based care. He's led one of the most successful Medicare shared savings programs, ACOs, in the country, with nearly $500 million in total realized savings. This includes over 40 value-based contracts, contributing to over $1.1 billion in value-based payments while managing over $1.2 billion in capitated revenue. Interestingly, he began his career at Advocate Lutheran General Hospital as a lab tech in 1992. He then had a brief tenure at AT&T, where he built upon his operations leadership and brought best practices from an outside industry into his future roles. You're going to learn all about it here on the show. Welcome to the show, Don.
Great. Thanks for having me, Larry.
Oh, it's our pleasure. We're going to pick your brain for the next half hour. I always like to start the podcast by allowing the guests to tell us a little bit about themselves in their own words. I gave your history, but tell us in your own words, tell us about your career journey. How did you get to where you are today?
No, it's a great point hearing you talk about my career. I'm a lab tech by background. And if you really get to the core of who I am, I'm just a curious guy. And when doors open, there's an opportunity to do something new, learn something new, I'm all over it. My wife would tell you I'm a well-rounded geek, and that has served me incredibly well. I'm basically a fact-based problem solver who loves to activate teams to get results. So as you talked about, I've been super fortunate that as doors have opened, people have given me that opportunity. But my heart of hearts is I'm an operator. And as you hear me talk about value-based care, I believe organizations that treat value-based care as a part of operations are those that are going to succeed. Those that do it as a side hustle or this thing in the corner are going to be less so. And that's really based on my history, as you just talked about. Everything from lab tech, the researching, the process improvement, computer programming, analytics. But I've been VP of Ops and SVP of Ops and President of Advocate Physician Partners for the better part of the last 15, 17 years. So to me, that's really at its core is how do you use operations to drive these type of improvements?
Well, I love that. I love what you just said because it's so critical. We talk at PTAC all the time about the fact that our value-based care initiatives have to be good for the business of the healthcare entity we're trying to work with. And boy, operations, that's exactly where it has to go. Okay, you have grown in your career over the same course of time that Advocate has grown. It started at Lutheran General Hospital, but now it's this multi-state entity. So tell us about Advocate Health and APP.
Yeah, great. Now, so Advocate Health now, I think folks are aware, December 2022, Advocate Aurora Health, which was really the large IDN in Illinois and Wisconsin, merged with Atrium Health, who was in North Carolina and Georgia and South Carolina. So collectively, we're about a $33 billion organization. I believe we're the 3rd largest non-for-profit IDN in the country at this point. So we've definitely had to learn how do you go from subscale to scale. Unfortunately, as I pivot and think about value-based care, population health, it is truly best done at scale. And I can talk you through a little bit about that. So if you look at population health from an Advocate Health perspective, the way we think about the world is we have 2.4 million lives in some form of a value contract. Loosely maps the HCP land. It's anything from pay for performance all the way to global capitation. It's everything in between: shared savings, upside, downside, pro cap, global cap, etc. But the way we manage those folks is we have 13,000 physicians and 73 hospitals engaged, but the way we engage them is across our networks. So we have 13 networks, and think of a network either as a clinically integrated network, an accountable care organization, or even just an employed medical group. So we have 13 networks, and you mentioned value-based contracts. As we've gotten our feet on the ground a little bit more and have really tallied them up, we're up to 117 value-based contracts. So what you learn and everybody knows is healthcare is very local. So how do you get the economy of scale of being this large entity, but be very local to what's going on in Georgia or North Carolina or et cetera? So that's kind of the way we think about it. If I pivot a little bit to Advocate Physician Partners, as you mentioned, I'm president of Advocate Physician Partners, have been president for the last 9 years. But one of the things, if you dig into Advocate's history, we're one of the folks that actually coined the term clinically integrated network in the early 2000s. And one of the things I like to say is we were doing pop health before it was cool. So in the early 2000s, our founder, Dr. Lee Sachs, was really focused on how can we improve quality while lowering total cost of care. And a clinically integrated network is the way to think about that. So Advocate Physician Partners, you'll hear me say APP, consists of roughly 4,500 physicians, about 1,800 of which are employed, and the remainder are what we refer to as aligned. Let me explain aligned for a second. Aligned are independent physicians, but we call them aligned because they're part of APP, which aligns all the physicians and the hospitals together to try to accomplish this, improving quality and lowering total cost of care. So we did a lot of firsts. We had our first commercial ACO since 2011, actually predated MSSP a little bit. And you mentioned savings from CMMI with the most recent announcement. We've saved just shy of $1 billion, around 900 million, give or take. So we've been very successful for an IDN-led MSSP.
Well, and the listeners have to realize how uncommon that is to actually be able to save that much money in a Medicare, shared savings program. Most of the ACOs do not save, and so you are unique in that. I want to spend a little bit of time here talking about the difference between the APP aligned physicians and your advocate medical group who are employed. Now, to be honest, I was an APP physician for many years because when I was in the leadership of the Illinois Gastroenterology Group, we were part of APP. But there's a difference between a physician being aligned and a physician being employed. Or maybe I'm not using the terms right, but a physician who is contracted with you, but independent otherwise, versus a physician that is employed as part of Advocate. How do you get the hearts and minds of these contracted physicians? How do you keep them rowing that boat in the same direction you're trying to row?
Right. And you're exactly right. There's really, the way we think about it, there's employed physicians that are employed by Advocate. There's independent physicians, which are physicians on our medical staff that are not employed nor in APP. And then there's aligned doctors who are independent physicians that have chosen to be a member of APP. Frankly, the way we work with everybody is a little different. We don't do anything with the independents, but we have the same standards and expectations for our employed and our aligned physicians. But the difference between them really comes down to there's a much more in-depth structure on an employed medical group, right? They're large and they have the system backing that they can do things for them. For aligned physicians, we work very closely with them. We want APP to be a benefit to them and to their patients. And we do that in multiple ways. We take a lot of the administrative burden off their plates. So we do credentialing, we do single signature contracting. So they don't have to meet with the payers, do their contracts. We do the credentialing so they don't have to credential with each payer individually. We have group purchasing of certain things that make it easier for them to participate. But probably what makes physicians most interested in being a member of APP is we're really deep in the value-based contracts. And as you know, if you've ever delved into a value-based contract, they're complicated. I'm not sure that payers even understand what they are sometimes. And trying to sift through that as a 1 to 2 or 3 physician practice is really difficult. We take that burden off them and we translate it to, look, you need to improve hemoglobin A1C, or you need to get colonoscopies done, or you need to control hypertension. We can boil it down, and then we have an analytics department that really teases through the data and says, where are the opportunities? So make it a lot easier for that physician, because no physician wants to have to do, hey, I'm going to check this box and say I did quality. No, they
Right.
actually want to do real quality.
Right.
So we're here to help them succeed. And because of our contracts, when they succeed, they're financially rewarded. So it's kind of a win-win situation.
So, this is consistent also with what we've said at PTAC, that risk should be held at the level of an entity like your ACO. But really, the providers themselves should not be at bidirectional risk. They need incentives built into their contracts so that they perform, and their performance then makes things better for the entity in itself. So I would imagine it's hard to continue to refine those incentive packages.
Yeah, so I mean, we keep it fairly simple, and we've gone through, I'm going to say about 4 or 5, maybe even 6 different approaches to incentives. We learn, we get smarter. Physicians learn, get smarter. We listen to our physicians a lot. What is really going to really work for them? Our most recent design, we actually use behavioral economics at its core. And so I'll give you an example. It used to be, hey, the target for mammograms, the number of screenings, here's your target, it's X. Theoretically, you hit X, you could stop trying to, get patients to get mammograms. Now, good clinicians don't just stop. If you're
Right.
a female
Right.
that needs a mammogram, they're going to keep doing it. But from an incentive perspective, you could step back and say, as long as I get X, I get there. Part of behavioral economics is there's no cap. You can keep earning be rewarded all the way up to 100%, as an example. We also, one of the challenges, and this comes with getting data from payers and whatnot, is just knowing which patients have open care gaps, right? Knowing which patients hemoglobin A1Cs are not controlled or hypertension is not controlled. So one of the things we're able to do is we're actually able to put up a website where our doctors can go in and see effectively what other incentives are still on the table and how is that tied to them closing the care gaps. So we try to make it all about the patient. And so when we talk, there's a lot of numbers in this space, as you know, but when we talk about the numbers, we're always very clear to say, not getting to 100% of control or 100%, yeah, let's go with control. 100% of hypertension control means we probably had X number of strokes, A1C not being controlled, you have this much kidney failure, this much eyesight loss, et cetera. Because it is really about the patient. And I think what our clinicians want, how can they do the right thing without being burdened with this huge administrative burden? And that's what we try to do.
Well, you've certainly been successful so far. I'm going to break here for a second. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Don Calcagno, Chief Population Health Officer at Advocate Health. Don, you've had significant success at Advocate. You were an invited subject matter expert at our recent PTAC meeting, and you discussed some essential success factors you have to have in total cost of care models. I'd like you to tell the listeners about these tenets that you mentioned.
Yeah, when you really break it down, I can sort it into what I'd call basic and advanced. And so if you just start at basic, like if you're going from a completely fee-for-service model to a value-based care model, what are those basic things you need to do? And the number one thing is resources are limited or there's a lack of infrastructure. So again, if you're an individual physician, small group, 5 or less physicians, it is very difficult to have the resources, the infrastructure to help you succeed. So how do we make total cost of care models where that infrastructure is covered? Second, and it ties to that is funding upfront costs. So moving fee for service to value-based care, again, that infrastructure, do I have to fund it myself? And to your point on risk, am I going to be rewarded eventually for that? Or is that a potential loss? That kind of thing. And then one of the things that people I don't think spend enough time thinking about, the opportunity for success in value-based care differs based on where you're starting. So what your baseline spend is. But
Yes.
if you look at Medicare Shared Savings Program across the country, so many people focus on the percent savings. I think that's kind of the wrong way to go about it, because if you're starting from somewhere that has very high per beneficiary per year spending, it's going to be easier to find opportunity to improve that. Meanwhile, if you're going where it's already a very well managed population, it's going to be difficult to make that savings. So where you start matters. So if you're entering a value-based care program, again, if you're a small physician group, not part of a CIN or an ACO, it's going to be tough for you to understand, like, is this a realistic opportunity or not? And then lastly, the risk of financial losses. I think in healthcare, most folks are trained to be risk adverse, which is probably a good thing. But then if I'm asking you to take on some downside risk in a contract and the payers have more actuaries and data and whatnot, am I really going to be bearing these losses, or is there a way to protect me from those losses, either through reinsurance or corridors or things like that? So that's what I think of as a basic. And you go through a lot of other things, but when you get to really advanced, kind of where Advocate Health and APP are, is how many degrees of flexibility are there in these models, right?
Yeah.
So CMMI comes out with a new one. Take REACH as an example. They have professional risk 50-50, professional risk 100%, global risk, right? So they give you some degrees of flexibility as to how to pick. Second is you get really good at risk adjustment. One of the challenges in all these models, I'm sure you've never heard it if you talk to a physician, but hey, my patients are sicker. ACOs, CINs, we do the same thing, right? Our patients are sicker. So how is risk actually be quantified in adjusting accordingly? A perfect example, in Illinois, one of my frustrations is we use more skilled nursing facility days than we should if you look at all the metrics. You then go, okay, maybe I can risk adjust it for that population. Well, it turns out HCCs, which is how MSSP thinks about things, HCCs are not a good risk adjuster for skilled nursing facilities. So how do you then go about risk adjusting? And then I think like much of the rest of the country, how do you begin to weave in these non-medical things, social determinants of health, transportation,
Right.
zip codes, food insecurity, all that good stuff? And then the last thing I'd leave you with is we think a lot about the continuum. As I talk to peers across the country, we include hospitals in all of our value-based care structures. And the reason is we think the continuum is so important. It can't just be primaries, can't just be specialists, be primary specialists in hospitals. And one of the things that keeps me awake at night is a lot of disruptors come in and pick off a sliver of that continuum, which actually
Right.
fragments care more.
Well, the other component that needs to be included are drug costs.
Yep.
And oftentimes they're limited. But I want to just touch on two things you said. I love hearing funding of upfront costs, because to take a value-based care contract as a practice and know you're not going to see a dollar for 18 months. You're not going to invest. You're not going to build that infrastructure, and you're going to fail. And if
Yep.
we want them to succeed, we've got to be cognizant of that and make sure that we're trying to feed things up front. I know that's what we do at Sonar. We actually pay these physicians a monthly fee to build the appropriate infrastructure. And that is so critical. The other thing is this risk adjustment. I harp on my colleagues. You can't be using 0.9 ICD-10 codes for all of your billing. They're giving you these codes. You should be using your codes appropriately to measure the severity of illness that this patient had that you were taking care of. And you need to include all of those other conditions that the patient is suffering from. I remember when I was practicing at Advocate, and I was on the board of one of the Advocate hospitals, and we took a contract at the time. It's quite a while ago, but one of the first things Advocate did was a coding set of lessons for the physicians to make sure they knew how important this is in risk adjustment. And I just love the way you demonstrated that, because it's critical. It's
It,
success.
Yeah, two things I'd say on the infrastructure costs. One of the things I'm sometimes quoted as saying that I'll double down on here is if you want to succeed in value-based care, it cannot be a side hustle, right?
Yeah.
It can't be something that you're not serious about. You have to invest in it, absolutely. And then on the risk adjustment piece, this is where I think artificial intelligence and in the not so distant future is going to help us a lot.
Yes.
I don't think the models that we have for risk adjustment are sufficient right now. And I mean, you just begin to imagine what ambient listening can do,
Hmm.
adding in machine learning to actually understand what's going on with this patient. I think we're going to get more sophisticated models, which will only help and frankly take the game playing out of the system.
Yeah. That's the vision I have as well. I love the potential synergy we're going to get out of AI. I want to make sure before we're over here, I want to delve in again about dual attribution issues, multi-attribution issues. So this is a show focused on a specialty, gastroenterology. And so unfortunately, most specialists are all on fee for service. And vision myself, and I've published on this, nested specialty solutions inside total cost of care models. But that immediately brings on payment sophistication so that patients are dual or maybe multi attributed to multiple providers. Are you doing any work?
Yeah, one of the things that frustrates me and I'm sure others is when CMMI comes out with a model that effectively competes with an existing model. And the easiest one for me to give an example on is with Medicare Shared Savings, take chronic kidney disease, CKCC CMI's program. Basically, all the ESRD patients that are in MSSP eventually are going to end up being attributed to that nephrologist, which means that significantly lowers the baseline, the benchmark in the MSSP. As an example, I think we did an analysis in our Midwest ACO once. 26% of patients had some form of CKD, chronic kidney disease, but they accounted for 58% of the cost.
Yeah,
Now, it wasn't all kidney costs, but these were super polychronic patients. So if you begin taking that all out of MSSP, the MSSP model is not going to function anymore. And
right.
so how do you solve for that? And further, if you think about it from a patient perspective, most nephrologists don't want to treat that patient's hypertension and their diabetes, right? That CKD patient very likely is a diabetic, very likely has hypertension. They may have multitude of other things. And so again, anything that fragments that continuum, I think is hugely problematic. So I'm a big fan of how do we get to some form of nesting and as in all these things, CMMI's pen is the most powerful in a good or bad way, depending where it goes. And what are the details around that nesting? Because at the end of the day, what we need is people need to be rewarded for their work. And are we able to discern who's the one that's doing the work and their outcomes of their work? If you do that, then I think you can break apart that continuum in a fair way. But the details on how you do that are going to matter greatly.
Yeah, yeah. You and I are thinking down the same line here. Um, the days of carve outs, you can't have total cost of care models with a bunch of carve outs because what's left there will not have any more value
Yep.
based arrangements. So I'm totally with you. We've got to work on ways to nest these episodes, procedure bundles, and even longitudinal PMPM models for evaluation and management. So it's complicated, I know. You and I hopefully we'll see more of this materialize in our careers. Final thought: where do you see value-based care going in the future? I realize we had an election last week, so who knows where things are going to go? But where does Don Calcagno see it going?
Yeah, it's interesting. As I talk to my colleagues across the country, there's a lot of questions. Is value-based care here to stay or not? I firmly believe the US healthcare system needs value-based care. We need to get off the fee-for-service treadmill. I don't think we've got the right models yet, though. And I'll tell you, a lot of people think the right model is going all the way in the global capitation risk. Problem there is not all payers are capable of actually being your partner on that capitated risk. And second, you talk about infrastructure and complexity. It's going to take time for people to develop that skill. So I'm not sure it's capitation. I'm not sure it's risk, but it's not what we have today, and it does have to exist. I think a big part in my mind of the problem is this lack of trust between payers and providers. You look at these value-based care programs, there's too much black box. Like if we all were on the same page, we all agree how we're doing things and we understand it, and we can get to a point where there's parity between payer and provider, I think we'll be in a better spot. I think that's going to happen, but like you said, the election could definitely make it a very interesting couple of months or years.
Yeah, interesting few years. Well, thank you so much for being on the show with us today, Don. I'm going to watch what you do at Advocate from outside, because I think you guys are really moving the needle well. Thank you so much. Thanks to the audience for tuning in. You can access our podcasts on most all of the podcast platforms like Apple Podcasts, Google, Spotify, and others. Learn more about the show on the program's page on healthcarenowradio.com, and lend your voice to the conversation on X at HC Now Radio. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.